Well, welcome everybody. My name is Sahil Chopra. I'm one of the co-founders here at Empower Sleep. Um, a little bit about my background. I'm a physician by training, boarded in internal medicine, pulmonary critical care, and sleep. Super passionate about sleep and how uh, the lack of sleep makes us feel. I became interested in sleep when I was a pulmonary critical care fellow. Um, we were working crazy hours, 70 plus hours a week in the intensive care unit. And I, around that same time, our schedule was always bouncing between days and nights. And around that same time, we also decided to have a family. So we had two children under the age of two, and I just was not functioning well. Was super sleep deprived, felt like I was burning both ends of the candle. And I vividly remember uh, supervising a resident as a fellow who was doing a central line in the internal jugular with an ultrasound. And I felt like I was going to fall asleep. Like in the middle of that kind of like intensity, I thought I was going to pass out and fall asleep. And then I realized how important the lack of sleep is and how important like sleep is, period. Around that same time, we would see patients in our pulmonary clinic, and it would take them months to get in, months to get a study, months to get started on treatment. And the fact that I wasn't sleeping well or not getting enough sleep, and these people were not, to the problem of a broken sleep care system really resonated with me. And that's why I became really interested in sleep, decided to do a sleep medicine fellowship, was in Boston for a year. Got to work with amazing people in Harvard, and those guys changed my eyes, changed my vision of what sleep is. And, it's one thing to think about sleep as it's one way to think about, say, hypertension with the idea of I'm going to help somebody improve their hypertension. But it's a fundamentally different idea when you say that I'm going to help somebody improve their cardiovascular health. And I think similarly in dentistry, improving someone's like fixing a cavity is very different than improving their oral health. And similarly, the same thing is true in sleep. Addressing sleep apnea or insomnia is very different than improving someone's sleep health. And, our goal is to help people improve the overall health of their sleep so that they can live their life to their fullest. So that's what, we sort of stand for. And we have decided to start doing more webinars to drive awareness of how to look at sleep, not from just the standpoint of sleep apnea or insomnia or restless legs, but this idea of like sleep health and how do you help somebody improve their sleep health. And Dr. Carson and Dr. Czubiak have been gracious enough to join us today because when we think about sleep health, airway health is also a component of that. Dental craniofacial health is also a component of that. And I just wanted to interview you guys and learn more about your guys' perspective, your journey of where you guys started as just a general dentist and how you've sort of paved the path forward, not just for yourself, but for many of your followers who are interested in this sort of junction of where medicine meets dentistry, at least on the sleep front side. It's doing it in many other ways from the inflammatory side, gingival health side, but at least on the sleep side, would love to get your guys' thoughts, your opinions, and hear how you guys end up to where you guys are today. So thank you everybody for joining. Thank you, Mike. Thank you, Kathleen, for your time. I know you guys are super busy. And I'd like to start off with Mike. How did you sort of end up where you are today? Not in the trailer that you're in right now, but but
Sleeping on the
generally
street.
speaking, yeah.
Yeah, I in the late 80s, I was making sleep appliances, but I didn't know I was. I was actually making snoring appliances. I didn't realize I was practicing dental sleep medicine because I didn't realize that healthy breathing was quiet, was silent. I just thought some people snored. And so a lot of these appliances I made, yeah, they were helping people with their snoring, but they were actually improving people's sleep. And that was kind of curious to me. I didn't realize I had such a sleep problem for another 20 something years. I had, I was tired every second of my life. And so when I started hearing more and more about sleep stuff, it became more and more exciting to me, especially when I started thinking about root causes and thinking about how the lack of nice continuous flow of air will make our bodies disrupt our sleep and make us as tired as I was feeling, and that the root cause of that in so many cases is lousy anatomy. And I'm the king of lousy anatomy, as you guys can see. And so I I got really excited about what can we do to to really help people get to the root cause of their sleep disordered breathing. And then I realized that I didn't know enough. I didn't have the right tools. And so that's when my journey really kind of blew up, and it started off with my enlisting a myofunctional therapist into my life. And then I'll tell you that I still remember the night that I met you, Dr. Chopra. And it's like, okay, this guy, I was going to say this guy's a tool. This guy is a tool that I need to add to my toolbox so that I can really understand what I'm doing. And more importantly, understand what I don't need to be doing. Because as dentists, we love to fix everything and be the one that has all the answers. And, as we know in sleep, we're just at the beginning of learning anything about what's really going on. And so we really need the help of our more experienced, smarter colleagues, which I surround myself with, so that I can get to that next level. So I still feel like I'm a junior at this game of trying to figure out why some people bodies won't let them get a decent night of sleep. So it's been a fun journey, and it's really, I think, intellectually, it's been really exciting. I don't get any excitement anymore from doing a DO on number 29, but I certainly do by trying to get someone to not go to the bathroom in the middle of the night. So it's been a real fun journey for me.
Yeah, no, that makes complete sense. When I was in Boston, um, this was in the middle of just echoing what you said about not of knowing what you don't know. This was in the middle of COVID, and uh, acute respiratory distress syndrome is when people end up into the intensive care unit on a ventilator because of severe respiratory failure. And I remember one of like the gurus of pulmonary medicine just telling us, hey, I don't understand the physiology of this in this specific context. And coming from somebody who has, published hundreds of papers, who has written the guidelines of what is acute respiratory distress syndrome and how to manage these people, I think just knowing what you don't know is like the beginning of beginning to learn what you can possibly know. And man, I totally agree with you on just being aware of what you know and also being aware of all the things that you don't know, because I think that actually becomes your superpower.
Yeah.
Kathleen, I'd love to hear I know I've seen your TED Talk. It's got millions of views, and I have some context of how you end up in the craniofacial dental sleep space. But I'm sure the audience would love to hear a little bit about that too.
Sure. Yeah. I see the person that introduced me to the space is on the call. Hi, Dr. Hang. I hope you're doing well. I see you've joined us. Thanks. Yeah, I'm here early in my career. I, was a new mom the year I graduated from dental school. I gave birth to my oldest, and she's 22 now. So that tells you, how young I still am. And she was sick, really, really sick from a very early age, and nobody could figure out what it was. And basically, it ended up boiling down to she wasn't sleeping well at all. And it's because she wasn't breathing well. She was underdeveloped in her mid phase, and she did not have good breathing habits. She had enlarged tonsils. She was developing very narrow. And we had been to all the specialists under the sun that you can imagine, like everybody you could think of. And all we got for a diagnosis was failure to thrive. And that's hard. And it was many years of poor quality sleep, not just for her, but for me as well. And she was underdeveloped, not meeting the benchmarks in growth. She wasn't eating well. A lot of concern around her. And I met Bill early in my career, thankfully, and he asked if anybody had looked at her jaw development, how she was breathing, if she was breathing well when she was sleeping. And I just said, I don't think so. I don't remember that. And I was already a dentist by that point. Nobody talked about sleep then. I think they barely are now. But anyway, that did end up being her issue. And we were able to get her tonsils and adenoids out at the time. That was what she needed, myofunctional therapy, did some jaw growth and development, got her developing along the right way. But it really opened my eyes as to what I was treating in my practice. I've never been a pediatric oriented practice. I'm mostly adults. But if you see the kids developing poorly and you see what they turn into as adults, it doesn't take long before you start recognizing that this lack of sleep and unhealthy breathing at night are contributing to a whole host of problems. And as dentists, we're seeing them every single day. We're seeing the gingivitis, we're seeing the breaking teeth, we're seeing the narrow arches, the crossbite, the failed ortho. I mean, the list goes on and on and on. And all of a sudden it was like, whoa, this affects so many people. Of course, there's so many other things involved as well, but we have such a big component that we face every single day to help our patients be able to breathe better and therefore sleep better and perform better. So once you start seeing it and start treating it and seeing your patients come back and tell you how great they're feeling and thank you so much, and you've changed my life, or you've changed my husband's life, or, my kid no longer is climbing the walls and they're sleeping through the night. It just takes that little bit of reinforcement before you're doing more and you're doing more and you're doing more. And like you said, Phil, you realize the more you learn, the more you don't know, because all these other avenues open up. And with like what you're doing with sleep medicine right now, I think what we've been looking at with sleep, we're missing the mark in so many places because we're not looking at the night after night after night and the patterns that you're starting to look at with our patients. So for me, that's exciting to be able to surround myself with colleagues that, realize the more we know, the less we actually know. It just takes us down further the next path. And, how can we get people breathing better, sleeping better, feeling better, and really bring this collaboration together? Because if we work together, we're going to go so much further. So what you've allowed me to do with my patients and Mike to do with his patients, I literally just saw somebody that you saw last week. And he is feeling so great and doing so well. And it is, a fraction of what I'm doing and a chunk of what you're doing. And then the other things we've introduced him to, and he's coming in going, I feel like $1 million. And it's just, it's a great place to be. So I love working with people, everybody who's on the call. I see a lot of people in the same boat. Dr. Arnold's here and Brian's here. That really just want to look at sleep and holistic health from all these different avenues so that we can help each other. So anyway, that's my spiel.
Yeah, no, thank you. You reminded me of this thing that we do in the intensive care unit. It's called the ABCDF bundle. And the idea is when you have a multidisciplinary program for patients, and in the intensive care unit, it's a mix of like the respiratory therapist, it's a mix of the nutritionist or the dietitian, it's the mix of the nurse of that day. You have physical therapy involved, and then you may have one or two other specialists that are involved in that patient's care. And when you round on that patient with that lens and everyone has something to contribute, the overall outcomes are better. And sometimes they can be so good that you have patients who are intubated, but they're walking, which is like, it's a wild thing to see, because you have physical therapists in helping patients in bed do their range of motion exercises. They have the proper nutrition. The respiratory therapist is weaning the ventilator as tolerated. And these patients are able to do these magnificent things. And at least I'm seeing the same thing in sleep. When you cannot look at, say, just one sleep disorder in isolation. when you address sleep apnea, there's usually a component of insomnia. There's a component of poor behavioral habits. When these patients have, say, a dental appliance, the pressure requirement from that artificial pressure that we're giving them with a PAP device, that sometimes comes down. And having this multidisciplinary approach in sleep medicine is so important, because not only do certain things influence someone's sleep, but if someone is sleeping poorly, that influences something else downstream. So the sleep and other medical conditions have such a profound bidirectional relationship that when we address all of these things in parallel, outcomes seem to be far better. And the fact that we can communicate with each other, in the sense, like, if I have a patient who I don't know if they're a good candidate for a dental appliance, and I can just shoot you a text or an email or something of that nature to close the loop very quickly, for me, that's super helpful and super beneficial. So thank you. So you guys have been doing this for like quite some time now, and like over the years, what do you feel, Kathleen, has been like the biggest obstacle of like from going from pure dentistry to having this very integrative approach of dentistry with airway, with craniofacial and sleep combined?
In order to be successful at treating this in a dental practice, you do need the ability to collaborate with other professionals, like-minded professionals, but also have a well-trained team on board to be able to talk to your patients and support what you're doing. So I would say some of the initial challenges for somebody getting started is to get your team on board, and then find ways to talk to your patients, to meet them where they're at and approach them, from their chief concerns. You might see something that they might not recognize, and just knowing how to communicate that with somebody so that they're open and receptive to listening. But early on, it was finding that network of other providers, because we really can't do this in isolation. I mean, we're only going to be so successful as dentists helping our patients sleep and breathe better to a small degree. It really is, we're a small piece of this puzzle. So finding those professionals, whether it's local doctors that understand what we're doing, or if it's somebody, like you, Sahil, who we can introduce to remote medical facility, that's been absolutely phenomenal. But working with people that really truly get what it is we're doing on our end of things, are what we can achieve, what our limitations are, and then how we can work together. So that's where I think, when we talked about putting this webinar together, I'm like, this is fantastic, because working with somebody like you has really enabled us to help our patients astronomically better than we ever have before, because you do take the time to understand. And like you said, if you want an opinion on a dental appliance and maybe you don't know quite what that would entail, or if this person would be right or not, we can just shoot off messages back and forth. And I feel the same way about working with you. Like, you know what, I've done the best I can here, and the AHI is actually looking pretty good, or they've been referred and are, getting structural remodeling, whatever it is. But we've kind of reached the point where our numbers are looking good, but they're still not feeling great. What do you see? And so being able to have you and people like, Dr. Arnold on here, look at the patient and say, okay, these are the other things that we can tick off, because it's not just all about the AHI. And we know that. So that was initially the biggest thing. But I feel like as we move forward, we're tackling those, and having these relationships make that possible. So.
For sure. What about you, Mike?
Yeah,
Even though I know you're a genius and you had it all figured out in the beginning, but would love to hear a
I
little
knew
bit.
nothing, and the collaboration thing is so key. But when I was making mandibular advancement devices, like I said, starting off with just being snoring and then getting more into sleep, I actually didn't know what I was doing. And it's a really uncomfortable place to be, especially for most dentists, because we like to be micromanagers, control everything, know everything 120% before we go after it. And some people were being helped with them and some people weren't, and I had no idea why. And it was really tough. It was tough. And this idea of needing to kind of know and cure people with things, it's such a different state of mind that the dental community, where so many of us are, we just feel like we've failed if we haven't, cured this person of their multifactorial disease, chronic disease. And so being able to let go of that. So one of my big obstacles was letting go of owning people's chronic disease. And when I did that, it just, I'm going to help you the best I can. I'm going to get you the resources that that luckily I have accumulated over time. And we're going to get you your maximum medical improvement and not feel like I have to, like, it's a failure if they don't get to be the best sleeper on earth, because there's still head scratchers out there where we're just like, man, this is what we know. And that concept in dentistry can be tough, but it's also the key to freedom. And as soon as you let go of having to own every outcome, it's so much more freeing. But at the same time, can you get the best outcome if you don't collaborate, if you don't enlist the help of others, if we don't talk about these things? And I always say, even though you see, we may have been doing this for the last 20 years, but I still feel like a pioneer in this, that there's still more to learn. As long as I accept that I want to help the people I can, even if we don't know everything, I'm still helping people. And one of the first people I helped was a really cool success story. This guy was so tired all the time. He had clicking and popping in his left joint. He had insomnia for a couple hours in the middle of the night. And now this guy has no more sleep apnea, and he can stay awake on a Thursday afternoon to do a webinar. And that guy is me, So I really delved into this for selfish reasons, because I wanted to fix myself. But it was also kind of cool because when you get to experience it, like, I may place an implant on a patient, but I've never had one before. I don't know what that's like, but I can tell you, I have lived the sleep disorder world firsthand, and it's been really helpful. So my mind shift was, so, as most things in life are, the obstacle that gets in your way the most often is yourself. So I had to, like, lay back, get a new attitude that I don't have to solve everyone's problem myself, don't own their problem, do the best we can. And then it made me way more effective.
Yeah, in medicine we refer a lot. We and even even if you talk to many specialists, diabetics, it's really interesting because when you have continuous data, it becomes very clear how what we thought would look so beautiful is not so beautiful. And a really good example of this is like diabetes care, where people's hemoglobin A1C may come down after 3 months after you put them on something. But the second you give them a continuous glucose monitor and you let them track their blood sugar over time, it's really wild because you'll see these like peaks of like 160, 180, and sometimes you'll see these like drops and these troughs in the middle of the night, and it's very eye-opening to see that even things that are chronic disorders that we thought we were doing a very good job on fixing, they're actually not being fixed. And the same thing is true for hypertension. If you give someone like a non-invasive blood pressure monitoring device, there will be peaks and troughs of their blood pressure during the day with exercise, with sometimes, during sleep it should drop, but it's just really interesting to see that data, and it just highlights how little we know about chronic disease management, because there's just so much variability in all of these things, and chronic diseases usually cannot be completely fixed. And we just give patients their goals, like, this is my goal for you, this is the best that I can do, and as long as we are in this goal and as long as you are functional, we are in a much better place than where we were before.
I think you make such a good point about continuous monitoring. Our advances have been to develop tests for A1C, which is almost like going backwards, because now, hey, we have this average. We don't know whatever led up to this, but we can tell you you're bad. And like, how does that really help you? It's kind of like getting your water bill 2 months later. Hey, yeah, I used a lot of water in May. It's like that tells you nothing. I mean, okay, man, next May I'll try to do better. So it's I'd love the idea of technology and giving us that ability to have easy little wearables that you can get great data from. I mean, my first polysomnogram when I was 42, and I had that because I had AFib, which is very related uh, to sleep apnea. And I was told I'm fine, I don't have any problems whatsoever, yet I had all these symptoms. And so the idea of being able to have wearables that get night after night data, and you can fool with things, and hey, maybe if I eat more mustard during the day, I'll be healthier and I'll sleep better. Who knows? How do we really know what is going to help someone unless we get more data? So I love that's anyway, not that I'm trying to be some about that.
Yeah, no, thank you. Thank you.
Okay.
Kathleen, how many nights of testing do you do in your office for your patients usually? Like, how do you typically, what does the patient journey typically look like once they come to you and you're having a conversation with them?
So it depends on how they find me. If it's somebody that's coming in because they have TMJ or sleep issues and they want to look and see what we can help them with, they'll come in and we'll do a full series of records, which includes a CBCT and a radiology report, and then I'll send them home with the sleep imaging typically. And I want at least 3 nights of data. Usually I have them take it home for a week. Because you're not always going to get a good night's data. And like you said, Mike was just alluding to, like, it's amazing. You can have 2 nights that look okay, and then you get this random 3rd night. And then, and so you really, those 1-night pictures have to become a thing of the past because they're just, they can't be that accurate. So we're doing minimum 3 nights. Typically I want about a week's of the sleep image rings. And then, the dental stuff. So if they're coming to me, we're looking at structural stuff. We're looking at how they've developed, we're a dental, obvious dental signs, things that we can help on my end and use with appliance therapy. Sometimes I can help them, sometimes I can't. Usually I'm sending them over to you to take a look at things as well. But if it's, let's say, a new patient, so those are the people that find me specifically for them. They know they have an issue, or they think they do, and they're coming in, and that's an easier straight route. More often than not, though, if it's just a new patient to a dental practice, like I just saw 2 of them this afternoon that have some obvious signs and symptoms, you talk to them about the dental, and then you kind of, that's the importance of the team knowing what they're talking about. The hygienists know what to say, the assistants know what to say, and you're kind of leading them along this discovery. And then we've started just basically giving out the sleep studies for any new patient. You know what? It's part of our exam. It's what we do. This is what we look at. It's not any more skin off your back. Wouldn't you want this data? And every now and then we get patients who either just don't want to do it. They're not tech savvy enough to, open an app on a phone. There are still some people that literally, no matter what you do, just can't figure something out. So they get to bypass. But I'd say by and large, the vast majority will do the sleep test, and it's interesting, and I'll talk to them about it. And then that's where it can be hard, because it's fun to, explore and see how else you can help somebody improve their sleep. But having the ability to say, like, somebody that I'm going to be sending over to you after this webinar, I'm telling him, he's going, I know I don't have apnea issues. I am not rested. I'm not feeling good. I know something's up, and I just don't know how to look at it closer. And I was like, I've got the guy for you, and he's going to let you keep this ring for even longer. You can have months of data, and you can look at it all you want. But that's usually, it depends on why they're coming to see me, long story short, but somehow we always manage to get, or at least try to get, that 3 to 7 days of data. And if we feel like they need more, then, you've got the program where they can keep it for a while.
Yeah. What does your initial evaluation look like, Mike?
Yeah, I'm similar to Kathleen with, I like to get at least 3 days. But what really kind of freaked me out was when I realized how messed up we can make people by the dental work that we do. like with myself, I was a 4 bicuspid extraction ortho case, which pushed my tongue backward. And I spent most of my life holding my tongue forward out of my pharynx. But as I got older, it started to fall back for making conditions even worse. Well, I didn't realize that the tongue even mattered. I went through my whole career mostly without ever like considering the tongue, so that when we do things like give people a night guard or a retainer or any sort of orthotic, is that making them better or worse? And so to be able, when I send them home, if there's anything, if some nights you wear a night guard and other times you don't, or if you do every night, do a night without it. And I like to get all the variations and things. Do you sleep with your cat? Well, do one night where you're not with your cat. Let's see if that's it. You want to blame your spouse? Cool. Let's do one night with your spouse and one night without it. You just can't bring your spouse to a sleep lab and okay, they're just gonna jump into bed with me with all, you can't do that. So I love all of those things because I've found out on one guy, it's like every time he eats onion rings, he gets stuffed up and then he doesn't sleep well that night. How do you get to that without doing multiple nights of testing? So I think that people should be tested like every night for the rest of their lives. And anytime you want to dig in, it's real data driven stuff going to be figures this out because there's going to be something that just don't even see or know. But I'll tell you, the family cat's a big one. I'm not advocating for people losing their cats, but maybe I am.
Yeah, I know. For me, doing multi-night testing has been so enlightening because you get to see what you did not even know. And it's almost as if like somebody turned on the lights in the dark and it's like, wow, there's all of this stuff going on. I mean, I have so many like countless examples where uh just by sleeping on your side, taking Allegra and having maybe like an incline wedge, a 50% reduction in apnea indices from like the high 40s to the mid 20s. And if that happens, that opens up many more therapeutic modalities than where they were to begin with. I saw a lady 2 days ago who's in New York, and she tried a whole bunch of things and nothing was really helping on the conservative side. And we just happened to have data from 3 months ago. And her mean apnea indices and sleep quality indices were 50% better than where they are today. And like nothing really has changed. And I'm just trying to dig a little bit deeper to understand what's happening. And then she tells me, oh, you know what? My allergies have picked up now because it's just that time of year. And if had I not had that data when her apnea indices were in like that 7 to 10 range, now they're in that 15 to 25 range, it's a very different conversation. And now it's like, well, let's try Allegra and see, or cetrizine or whatever, pick your drug and let's try and see what happens. So having longitudinal data for us has been such a game changer in understanding someone's biology and then also then understanding the treatment response. If I'm doing something for this individual, is it even working or not? And getting to see and track it over time. So that's been super exciting as well.
There was a question in the chat about the various sleep tests that might be used for multi-night sleep testing. I know that Dr. Carson already replied, but maybe it's worth expanding a little bit more on this.
Yeah, absolutely. So we use a mix. We house multiple different tests in-house. Sleep Image is sort of our workhorse. We have night owls. We have watch pats. We also have a level 2 test. A level 2 test is an unattended multi-sensor study. It's basically what would happen in a lab, except you can do it at home. So it measures sleep directly at the level of the brain, and you can also measure limb movements, and you can measure all sorts of interesting things. So we have a unit of that for some of the more complicated cases. If they don't want to go to a lab to get an in-lab study, we can mail them a level 2 study and get that same high quality data but the patient can get it in the comfort of their home. So that's been really exciting to have. So it's important, I think, to be test agnostic, because there's really no perfect test. But they're all, but when we mix and match and combine different tools as clinicians, I think it just makes us a better clinician. And as long as we understand the data that we are looking at and how to look at it, it becomes easier to understand the limitations and the pros and cons of each of the tests, and then one can use the right test in the right situation. Those are the tests that we're using. Mike, Kathleen, what other tests do you guys have in-house?
I use
So
that quite a bit too. Sorry, hey, I'll let you go next. Yeah, mostly Sleep Image is my workhorse, just because you can get the night after night after night, and it's consistent with the same piece of equipment. And then the WatchPat, I've used the WatchPat for a long time. I've played with all sorts of home sleep testing devices that have come out over the years. I just landed on those are the two that the patients seem to do the best with. They're the easiest data for me to gather, and are pretty well accepted. So that's what I default to now. Are you using anything different, Mike?
I also have a watermark that I use besides WatchPad, and the Sleep Image is definitely my workhorse. There is a little information I use my WatchPad for, but the ironic thing about the whole thing is that our patients that have sleep disorders tend not to tolerate things very well. They sleep lightly, so everything bugs them. And so one of the things I love about the Sleep Image one is it's the least bugging of any of the other ones. So I use that the most to screen, but sometimes I'll need the other stuff. And I think the multi-night ability without costing a ton of money, because with my, I don't know, the WatchPad, it's probably $70 a night in disposables and things, and it's harder to do multi-night. So I just love I love the fact that we can do that stuff, and I really think it's important to do home testing also, because again, people do so many things at home that affect things, like have a really dusty carpet in their room, or they sleep with an animal, or they have a dog coming in all night long, or or they have some alcohol before bed most nights. It's really great to be able to have people in their natural environment and see what actually matters and what doesn't.
Yeah, for sure. But let's say you do a sleep test. You've done your records and you've had this conversation with the patient. You've reviewed the results. When do you think about referring these patients to someone in sleep medicine? And not everybody needs to be seen. I think some people benefit more than others. But how do you guys typically think about this, Kathleen, when to refer and when the patient doesn't need to be referred out?
Well, since if we're talking about sleep apnea, then they're always referred, because it's outside of our scope to be diagnosing a patient with sleep apnea. So if I'm find that there's enough red flags, or the patient's symptoms warrant, or if I think that sleep apnea is an issue, then they are always referred out, whether it's their physician that they're already working with, because sometimes they come in and they've got somebody they're working closely with, or whether it's you or a local in-person one. We usually have like the option of, here's my 3 choices for you, which one sounds better to you. We need to pull our medical colleagues in on this. Outside of that, it's if somebody comes in and it's not OSA, we're looking more at structural development to help them with better function of their structure, then a lot of times I won't go that route. But if those same patients have significant symptoms that we're not getting good resolution with some home care stuff that we hand out, some myofunctional therapy referrals, maybe our chiropractic colleagues, like there's other people that we rope into the treatment, and they're coming back and they're showing signs of sleep issues in spite of not having the numbers that warrant it, then we go to the physician referral too. So more often than not, but it really depends on what that screening is for, what the patient's symptoms look like, and then what our treatment plan is in the dental office. But absolutely every time, if there's a sleep apnea component, you got to find somebody to work with. So it's, I said, it's either I give the patients, the options typically are, who's your medical doctor? Do you have a good relationship with them? Do you want me to contact them and go that route? Or I have, this person in person over here, that you can physically go to the office. It might be X amount of weight, or we have an online, physician that we work closely with. Which route do you want to go? And usually the patient will tell me, I want to do this, or, and we'll go that way.
Yeah. What about you, Mike?
Well, I agree with everything Dr. Carson said, of course. I'm really happy to, especially with the sleep imaging, the clues that it gives us for central sleep apnea. So if I see that there's a good chance it's not just all obstructive sleep apnea, but it's central, I definitely want to get a sleep physician involved with that. And when I do testing, I really am not doing testing, I'm doing screening, because I realize when I get the report back, I am basically screening. I'm not going into and looking at the raw data and looking at the plus and seeing, I don't know what any of that. I'm just a caveman. I like, I know what I know. So I'm looking for any of those clues that say, this is weird, or this person probably has a problem. And I realize the limitations of sleep testing. So I have to listen to the patient and hear their symptoms and see if it looks like it correlates with this, if it makes sense. But there's no part of me that wants to learn how to score. There is actually a part of me, but I know I'm not going to be scoring sleep studies anytime soon. And of course, we can't do our own diagnosing. So, but I do like to be able to screen. And I do think that every person on earth should be screened at least every 5 years of their life, because there's just so much underdiagnosis of it. And I think that's on the medical our community. I think we need to have patients be able to decide whether they want to treat their chronic disease. But if they never get tested, they don't know. So that's why I love the idea of having that part of your new patient data collection, is how are you sleeping, especially since it affects our dental work so much. All this, the chipping teeth, worn teeth, yellow teeth, TMD, just keep following it, just keep asking why. And you're going to, if you ask why enough, you'll end up in the care of Dr. Chopra.
Yeah, and then we're trying to figure it out too, because many times we don't even know what's the driver here, but we just do our level best. Yeah, it's definitely super complex, and sometimes we have patients who we're able to help them, and you can see a substantial improvement in their sleep quality and a substantial reduction in their apnea indices. And then sometimes things just don't budge, and we'll then refer them to a lab to get more details, to then understand if there's any potential targets. And most of the times we can help, or at least have some kind of improvement, but maybe 5% of the time patients don't get substantially better, and that's just a limitation of what we know. The other question that I have is, when you guys refer, and I think other sleep physicians probably have this question as well, is when you do refer these patients to a sleep physician, what are you guys like? What do you look for as a dentist? I know that we always want to send back all the notes. We want to send back all of whatever our understanding is of that patient and what we think could benefit them. But as a dentist who's helping that patient and is sort of that involved in their patient care, what is helpful information for you other than just quote unquote a diagnosis? And Mike, I'll let you sort of go first.
Okay. What really the information I want are the things that can really help me for what I might want to do. So if I'm be doing something like a mandibular advancement device or do some biomimetic remodeling of the airways, whatever is going on with it, there's certain things I want to know. And so I love things like body position and things like that. But that's a limitation because we don't have multi-night, at least I don't know of great multi-night um, appliance devices that can give me all that data all the time. But I love that. Love to know anything to deal with nasal congestion because I feel that our noses are so neglected. Also, it's probably even more important than the tongue, keeping that nose open. So I love to see the RDI, the RIRAs. I like to see fragmentation in the sleep, to see maybe it is someone's cat playing with their toes all night long, fragmenting up their sleep, or noises, the train running by their house every night. I actually like all of the data I could ever get. And so but usually I don't get that. Usually when I get a report back from a sleep physician, it says, here's their AHI. Maybe I'll get a non-REM and a REM AHI, which is also very helpful for what I do. But I just don't get a ton. Sometimes I'll get an ODI, but I don't get a lot. But I would actually love to see like all the stuff that comes out on a sleep image on their first page report. I just love that stuff. And then the second page I like also, which has more of the oxygen, all of that sort of stuff. But yeah, for all those things, I don't even know what's important and what's not important because I think we still don't completely know. I mean, a question as simple as how does an AHI really affect our longevity? I think some of the studies out there have been confusing for us. We're getting answers to that question that we don't expect. So usually when things don't make sense, it usually means we have to peel another layer of the onion off. And so once we do that, I think then things clear up. And I think, especially with the continuous monitoring, I think that's part of the unpeeling of the of this onion, so we can figure out what's going on. So it's these are really exciting times, I think, to be involved in sleep, and our patients are literally, I think, beating down our doors to get the help that they know they need, but they just don't know how to get that. So it's been a great time to be in this.
Yeah, for sure. Kathleen, what about you?
Yeah, when working with the sleep physicians, I think, at the beginning, historically, like Mike said, I'd get maybe a report that would say, here's the AHI, this is what it looks like with the appliance, without the appliance. We think it's working, we think it's not working. That was it. And I'd talk to my patient, and I don't even know that they would get that data from their interaction with their sleep physician. They really didn't have much interaction. So the ability to get information as to the communication that's going on with the patient, what else is maybe being recommended, whether it's any sort of supplementation, or like you said, maybe, try this allergy medicine, or, we do that on our end in our practice for the most part too. But when you're seeing patients, so the things that we don't think of that maybe you do to help a patient get a better night's sleep, communicating that to us so that we know it's out there and what our patients are doing, which you have a great portal set up and we can go in and see that. I think that's super beneficial because we usually aren't privy to that. The patients just come back with, they don't think it's working or it's helping and I'm fine. But taking all those extra steps and making sure that we know what's happening. I know the patients appreciate it. And then it also gives us more information so that when we talk to the next patient, it's like, hey, my other patient saw, Dr. Chopra or Dr. whoever, and they're trying this, this, and this. And it's something outside of what I would normally think of. And that would encourage them to work with other, with you guys more. And I think we'll get better results, anyway.
Yeah. One of the things that I always look for when we get referrals from dentists is it's always important for me to know if the patient from a dental standpoint is a good candidate for a dental appliance. Because sometimes when you're seeing somebody virtually, or even sometimes in person, like we don't have the domain expertise to really know if somebody's a good candidate for. We can see that, then we can count teeth, and I think that's probably the most I can do, and maybe look at a tongue tie because I've hung out with you guys, long enough, and you've educated me. But like as a sleep physician, many times I don't know who's a good candidate for a mandibular advancement device or a biomimetic appliance or some kind of a growth and expansion kind of appliance. I think that is useful information for me to have, because if someone is a really good candidate for something like that, then how I think about the problem could be very different, because then I can think from a multimodal standpoint. Like we should do this, but at the same time, we can also provide this sort of safety net umbrella, the safety net of care and therapy in the meantime, while the appliance does whatever it needs to do. So that is usually super helpful for me. When you guys send over the cone beam CT reports, I find that to be very helpful too. Knowing if like the maxillary sinuses are full, getting a sense of like, volumetric airway sizes, health of like TMJ. These tend to be very useful informations for I think sleep physicians to have also, as they're thinking about what are other, if a person would be a good candidate for a dental appliance. We're sort of coming close to time, and the intention of this was really just to share how sleep physicians and dentists and other specialties can really come together and be able to work in a multidisciplinary way, where the patient is really in the driving seat and all of us are just on the side doing what we know how to do best. But I would love to open this up for questions for everybody here, for either myself, for Dr. Carson, or Dr. Czubiak. Anything in specific? I know I saw a couple of questions that came in, Maxim, and feel free to read those out. But the intention is to just give the floor back to the audience here and hear any questions that you may all have. And feel free to unmute yourself.
As people are unmuting, there was a question in the chat from Dr. Leslie Holler about heart rate variability.
What was the specific question?
Whether when diagnosing patients or treating patients, how much each of you looks into the heart rate variability.
Yeah, it's a good. I mean, so typically, I can start off, but typically I don't look at heart rate variability. The HRV is a sign of cardiovascular health, but it doesn't really tell us much about if somebody has sleep apnea or insomnia, because those are diagnosed very differently. One thing that does happen in sleep apnea is called cyclic variation in heart rate, and CVHR on the sleep image reports. And that basically refers to a physiologic deceleration of the heart rate followed by an acceleration of the heart rate from the beginning of the apnea to the resolution of the apnea. So when someone stops breathing, there will be a physiologic deceleration in heart rate. And the second there is that sympathetic response and arousal from that, because of the apnea, there'll be a physiologic acceleration in heart rate. And that can happen from anything. It can happen from periodic limb movements. It can happen from, it's very common in sleep apnea, but that is something that I do look at. But one can trend, if it's trending in the right direction, if once somebody is on treatment, one should see that number go down. But in terms of using that information to make a diagnosis, I typically haven't used it. I don't know about Kathleen, Mike, if you guys take a look at that.
I look a little bit at it. Do you, Mike?
I do look at it. It really seems to be, I mean, this is just my non-science, my know-nothing opinion, but it seems like my patients that are the most anxious tend to have a higher SAI, the heart rate variability indicator. And and so I see it a lot in, my patients that are the most anxious or have depression or other symptoms that are obviously in up there with all of obstructive sleep apnea, but it seems like it's independent of the AHI. I mean, people can have really low AHIs and a really high cyclic variation of heart rate. So, and then I tend to see it a lot towards the morning time. Maybe people are more congested. So I don't know what's going on. Obviously more REM sleep, maybe more collapse, but it's just interesting to me. And those are the sorts of things that because of all the data on these reports, I'm looking at my patients and saying, who are these people that are showing up with this particular thing? So, I think I love that information. I'm trying to figure out how we can do, something with it.
Mm-hmm.
What about you, Kathleen?
Yeah, I think looking at it as a sign of, what your autonomic nervous system state is at, I do think, you notice the trend of the higher HRVs having more autonomic distress and just, so I look at it as a marker, and I like to see it go down. And I also have noticed, as you're improving sleep and breathing at night, you're going to see changes to that number. So it's to me right now, it's still a red flag. And I do use, I like heart math, for instance. I mean, basically it's training proper breathing, it's meditative state, calming the nervous system. And I think that helps everybody out, overall. So I do pay attention to it. But again, might be totally irrelevant and totally different than the AHI. So it's a different way to get your patient feeling better.
For sure.
To it. Mm-hmm.
Looks like Ryan has a question. Ryan, feel free to unmute yourself, and then Maxim, you can, if you don't mind reading the rest of the questions.
Absolutely. Dr. Arnold was first, so waiting for him to unmute. And if not, in the meantime, there are questions about DNA and MR. Oh, please, Dr. Arnold.
Can you guys hear me? Sorry.
Yes.
Okay, good. So, I mean, I've done some work with heart rate variability. I just wanted to add in there that I think it's, I haven't studied it as much in the context of an unrepaired patient who might still be experiencing apnea. But when you have maybe a physiologically more normal sleep pattern that is either corrected with appliance or with support, the variability is something that we've been studying now, for a while, and we've seen this use in the neonatal population, right? Monitoring for distress, and it's that when they lose variability from a previous presence of it, that's a sign of distress, and they've translated that now, and we've seen this work in cardiac patients as well. I'm interested, and I see a lot of it in early recognition of a disturbance in a patient's physiologic balance. So if their variability is known and being tracked regularly on even something as like archaic as like an Oura ring that has some variability assessment, the measurement of its delta can be very impactful for us, knowing that when someone drops, that something might have changed, that they can then get immediate feedback loop. And so, kind of going back to what you guys said about how important continuous monitoring is and knowing a patient's baseline, I find it be very effective to kind of finding something that's changed and they get a more immediate feedback as opposed to waiting, days or weeks later when you can't really recall the event, and they can look back and say, oh yes, I had eaten too close to bed, or I was exposed to someone sick, or I have the pet in the room, or I drank alcohol that night. Those things will impair, and variability will be an early marker that we'll see change that quickly.
Yeah, no, definitely. Thank you, Dr. Arnold, for chiming in there. So in summary, higher HRV is healthier. It's a sign of a healthier cardiovascular system. A lower HRV is a sign of a not as robust cardiovascular system. And a high cyclic variation in heart rate is a sign of some kind of distress going on. And a low CVHR, or cyclic variation in heart rate, is also a sign, is a good sign to have. What sometimes we do see is people who have the lack of cyclic variation in heart rate with an apneic event. That can also be a clue to some kind of a conduction abnormality. because that's a physiologic response that was supposed to happen. And if people who have had an ablation and they have a pacemaker, for example, the heart rate cannot go up as it's sometimes supposed to. So it's very interesting to see that in the cardiac population, because it does give us some insights. Thank you, Maxim. Any other questions?
There are a few questions from Dr. Daniel Flores. I was wondering, Daniel, if you want to unmute and ask, maybe join the conversation.
Hello, yes. Couple of questions. One of them had to do with the DNA and mRNA appliance from Vivos. And someone answered that it was a fixed appliance. So is that one way to just address the issue there?
I'll pass this question on to Dr. Carson, Dr. Czubiak.
Go ahead, Mike.
So, all right, I'll take this one. It's actually removable appliances. They're removable appliances that patients wear in order to get palatal expansion and changes in the bony structures, which can be of limiting. Like for myself, for instance, I wore a DNA appliance for 14 months. My palate expanded 8 millimeters. And now without an appliance in my mouth, I don't have sleep apnea anymore. And I feel like a whole different person. And so they call them biomimetic appliances. And so those can be very helpful in getting rid of the oral contribution to our sleep disorders. And for some people, they can be 2 millimeters. And I don't know if you're a dentist, if you've ever had this sort of thing, but I have finished someone up with Invisalign, and then they stick a retainer in their mouth that may be slightly thicker than their aligners were, and now all of a sudden they can't sleep, they're feeling horrible and all of that. That extra little thickness took up tongue space, it pushed the tongue back, all that. So for me, because I had teeth extracted, I had such a small mouth that my tongue just couldn't fit there. So when I expanded, now I had room for my tongue to be there, kept it out of the back of my throat, I was able to breathe, and things got way better. So it is one of those modes of being able, that's one of the things that can help with a more sustainable solution that actually is more of, of getting to the bottom of it. Most of the other things we've done, like my mandibular advancement devices, they could work great, but they just sustain people. They didn't really fix anything. And of course, we know the surgical, how successful surgical treatment can be also. So there's multiple ways of getting there, and you kind of have to use what works for you and what you're experienced with. And after I helped myself, I couldn't keep this away from my patients. So that is like my the majority of my patients are being treated by those appliances.
Okay, thank you. The other question I had was, how do you guys go about determining parasympathetic versus sympathetic apnea? And how do you go about treating each one?
I can take this. I'm not aware of any kind of parasympathetic versus sympathetic apnea. Sleep apnea has been phenotyped into either REM dominant or non-REM dominant, and REM is a more sympathetic predominant state. Non-REM should be a more parasympathetic predominant state, but it's still either during REM sleep or during non-REM sleep, and we don't typically think about it if it's during a sympathetic state or a parasympathetic state. And typically people who have REM dominant sleep apnea, they tend to have more hypoxia, the desaturations are longer, the apneas are longer, because that has to do with more upper airway relaxation and more it's usually more apneas rather than hypopneas. But when you have someone who has non-REM dominant apnea, and sometimes you can look at the oximetry signal to get a clue, is that those desaturations are shorter. The desaturations are you have a higher saturation even during the desaturation, and the length of the desaturations tends to be shorter. Sometimes these people have underlying AFib or some cardiac issue, but that's typically how we think about this, but not from the standpoint of sympathetic versus parasympathetic.
Okay, thank you.
Mike, I had a follow-up question to you of, you were talking about these Vivos appliances, these like growth and expansion type of appliances. What do you do when you have somebody who doesn't necessarily have a quote unquote small airway? They may be overweight, they may have a normal weight, but they also have sleep disorder breathing, but the scaffolding, but the craniofacial structure itself does not appear to be a predominant driver. Is that something that you run into often? And if if you do, and if this does happen, do these people benefit from quote unquote a larger airway?
Yeah, it's a good question. Yeah, I generally I run into very few normal size airways. It's like everyone is underdeveloped, it seems like, that have grown up in places like the United States. So we end up, in a way, mostly being underdeveloped. The question is, can you handle it or not? And so you throw on some weight, especially if you're someone like me. If I gain a pound, it goes to my neck. You get a fat neck like mine, and it's going to collapse you really easily. And so I never thought I'd be talking to my patients about losing weight. I just can't believe I'll bring that up with patients now. But yeah, weight's a big deal. And that's, I think, one of my big failures with mandibular advancement devices is like, yeah, you can be on your side, and if your neck's really heavy, you're going to probably collapse even, so that mandibular advancement is just, it's really irrelevant. And so you have to look at all of those aspects of life and of their anatomy. And there's no real, like when we think about normal good breathers, we always use like 38 to 42 millimeters in between the lingual surfaces of number 3 and 14. But, that's probably based on studies of white males, old white males. And so it's really not necessarily what's going to tell us about every single person. But I'll tell you, you start looking at tongues and you see the scalloping on tongues, that's not fitting in their mouth. And it's not because the tongues, usually it's not the tongue being too big, it's the arches being too narrow. So most people need some sort of expansion, but there are some people you just don't see, they seem really wide. Maybe they've had a lot of orthodontics. They seem like they have that. So there's going to be other things, and maybe it's adenoids, maybe it's tonsils, maybe it's just improper breathing, maybe it's tongue ties. There's so many things. And that's why, like, as you say, there's a lot of modalities that you can employ. And I'm finding that habitual breathing patterns are a huge part of this. And when you talk about sympathetic and sympathetic activation, yeah, you start breathing just with your chest and through your mouth, and you're going to be in a state of sympathetic drive. And so we need to get people back to nasal breathing deep with your diaphragm. That makes a huge difference. And if we can be doing that all the time, which helps keep our nose clear, then maybe we can get through the night without activating that suffocating sort of response in us. So I think it all works together, and whereas we try to figure that stuff out.
Thank you for clarifying. Maxim, any other questions here?
I think that's it. But
Arnold has his hand raised again.
Go for it, Ryan.
There are more, yeah. I actually think that the Dr. Arnold's hand has been up since the last question. Maybe we could take a question from Chad.
Hey, Chad, how are you?
Hey, good, thanks. Hey, I had a thought. I want to get your opinion on this. So Dr. Czubiak was just talking about breathing and how he's found that just breathing retraining and proper breathing technique has really been a good component of the treatment plan. So as a pulmonologist, I was wondering what, like, is, some of we have a company that focuses on like pediatrics and helping with proper growth and development to hopefully reduce some of this condition in the future. What about, like, how there's breathing strengthening devices, or where you measure the strength of your breathing as a pulmonologist? You send one of those things home that they try and breathe in or breathe out with certain, like, have you seen any correlation with just that as a form of therapy to help reduce or eliminate some type of sleep disordered breathing?
Yeah, like it's kind of embarrassing. As a pulmonary fellow, we talked about COPD, we talked about asthma, we talked about emphysema, and all we learned was like the physiology of breathing from like the brain stem and diaphragm and phrenic nerve standpoint. And ways to improve breathing and optimize breathing and no nasal breathing versus oral ventilation. Like the fellowship was not very focused on teaching us that. Sort of like how I've heard this from you guys. Dental school, they don't really talk about airway, or they don't talk about sleep and airway. The same thing was true, Chad, in my training. But what I can do is like extrapolate some data of how cardiopulmonary rehab influences patients who have, say, COPD or just had a bypass surgery and are now in the recovery phase. And those kinds of breathing exercises that activate accessory muscles of breathing, whether it's the muscles of the neck, the intercostals, or the main muscle of breathing like the diaphragm, these exercises help people increase their cardiovascular or cardiopulmonary endurance. But what those exercises do to, say, sleep apnea, I'm not sure. And I'd be happy to look this up and get back to you. I'm not aware of any specific quote unquote non-tongue breathing exercise that influences sleep apnea in a positive or a negative way. But it can improve cardiopulmonary function in a pretty significant way. It's a great question. Thank you.
Thank you.
There's one more question from Dr. Young.
Hi, when I see the sleep study report, I notice the AHI is pretty high. At the same time, I notice the stable stage is very low. And also it depends on the age. So how can I know, is it like if we helping to patient to increase the expansion of the palate area that improve AHI at the same time of the stable stage of sleep?
Yeah, so the question, at least what I'm understanding, is that there's a relationship between the apnea-hypopnea index and unstable sleep, and how that ties into sleep and airway. I'm not entirely sure how those two are necessarily related. What I can say from like a sleep test standpoint is typically people who have substantial sleep disorders, they'll have way more unstable sleep than stable sleep. And people who have sleep apnea, they may or may not have a substantial reduction in unstable or stable sleep. I see Kathleen and Mike smiling. I'm sure maybe there's something, an inside joke going on. But the relationship of that to the airway, I think, is a very clinical decision rather than like a sleep test decision. The sleep test only tells us what's the health of this individual's sleep, but the decision of how much of the airway is involved in this and how much the airway is driving that ends up being a, an exam-based decision plus a conversation-based decision. And I would love to hear your guys' thoughts too, Mike and Kathleen.
I'm waiting for Kathleen.
You're waiting for me. You know what? It's a really good observation, because I think, and I would defer to Sahil on this, but when the AHI is elevated, I take that back. There's been plenty of times where I've seen high AHI and stable sleep. So it is a very interesting mix. And I do agree with going back to heart rate variability, the people that have the autonomic distress going on, I'm seeing less stable sleep, just as an observation. And so if you can get that cardiovascular health back into a better position, then and again, it's just a correlation, because this is certainly not my area of expertise. I'm looking at what I'm doing structurally. It's just the observations I'm making. And then same with myself too. If I know that I'm going back to breath work, like we were just talking about, ways to breathe better, if I'm doing consistent, healthy diaphragmatic nasal breathing, I know I'm getting more stable sleep. Just my own visual, because I wear those rings just for fun, as I know Mike does, and I'm sure Sahil does too, just for fun on a very regular basis, to see what I can do to change my sleep in one direction or the other. And sleep stability, at least for me and my body, is very dependent on how I'm breathing and where my heart rate variability is falling. So that's an interesting area that maybe more longevity studies will get data on, but I don't know if it would have anything to do with us helping AHI and fixing palatal structure. I mean, possibly, because if we're helping calm down the whole nervous system that way and helping get people in a better homeostatic state, then intuitively it'll be interesting. I think that data coming out is going to tell us a lot more.
I just wanted to add. I just wanted to add very quickly. You can have good sleep and have substantial apnea, and you can be a poor sleeper who has substantial apnea, and one does not, and we see this frequently where people have amazing sleep but they have horrific sleep apnea. The worst combination is a bad sleeper who has sleep apnea. Good sleepers who have sleep apnea are easier to take care of. So the two are they're intertwined, but they can also be two separate problems.
Yeah, I kind of find that when I think about the body and I think, is our body really messing up, or is it just trying to do the primary function we have, which is getting our next breath? And then keeping safe. And so, because I think about this and I look at that, how much stable sleep a person's getting or unstable. And I kind of have to think that if we don't get stable sleep, there's probably some evolutionary reason for that, because it's really, during deep sleep, that's when we're at our most vulnerable to predators, whatever. And so so for me, it's kind of a signal that your body doesn't feel safe enough to let you get into that stage. I may be completely wrong in that, but I work with those, that hypothesis, and then I look at my patients to see if it seems to make sense as part of this, trying to figure this stuff out, because it doesn't correlate. Numbers like that, I looked at a patient, she had a AHI of 107, and she had great deep sleep, and she woke up in the morning all refreshed, and she was, ready to go. 131 AHI during sleep. Oh, and the hard work, the Energizer Bunny. It's like, meet my patient with AHI of 2 that can't get out of bed. It's like, so there's a lot, and that's why this whole data-driven, like you said, continuous monitoring and looking at that's going to be so helpful in us figuring out, because so many of our metrics are, what do they really mean? So that's why I think it is so important to really, try to make sense out of all of this. And so, anyway, that's that's just my observation. Again, like most of the things I say, this is just from me trying to machete through the crazy information, see if anything makes sense.
Yeah, no, thank you. Thanks, Mike. Thank you, Kathleen. We have maybe time for one last question. I know Dr. Czubiak has been kind enough to join us while being at a family in his family friend's wedding. So we'll let him go. If anybody has any questions, would love to hear it. And if not, just want to say thank you to everybody for joining. The intention here is to drive collaboration so there's better patient outcomes, so that I can educate myself from you guys, and hopefully you can learn maybe a few things from us, and really to drive better patient outcomes.